Super, great. Try not to leave the laptop behind at the end of this. All right. Okay, so if I don't indicate otherwise on the slide, I am going to be mostly talking about recommendations that come for GINA for asthma and GOLD for COPD, although I will mention some things that aren't in those recommendations. I will use a bunch of abbreviations. I have some learning objectives. As I said, I tried to pick some things that I thought would be useful. So asthma, diagnosing it is super tricky. We'll talk a little bit about SMART therapy, so single, maintenance, and reliever therapy. Something that I came across actually just this year or so that many of the guidelines are now saying you don't need to escalate to high-dose inhaled corticosteroid. And we'll do a quick overview of biologics. For COPD, I want to share with any of you who are not already completely converted to the idea that pulmonary rehab might be the best therapy we have for COPD, to try to convince you of that, that inhaled corticosteroids should be limited. There are a couple new medications on the market. I'll tell you a little bit about them and some of my skepticism. And we'll talk about who benefits from oxygen. And I see what Jason was staring at. There's this error message that keeps coming up, which is a little distracting. So, the diagnosis of asthma, why is it so tricky? Well, because we have no single test for it, do we? And the guidelines have changed over the years. So once upon a time, it was definitely just a clinical diagnosis, and then more recently, there's been a real emphasis on trying to get some objective data, and that's because we both over and under-diagnose asthma. And you can imagine that both directions are problematic in terms of using therapies that aren't necessarily effective and spending money and failing to use the correct therapies. So this is a flow chart that is projecting reasonably well, that comes from the European Respiratory Society guidelines, published in 2022. And it's interesting to look at. So you can see at the top of the flow chart that they're starting with, so they're saying if somebody has symptoms that are suggestive of asthma, and those symptoms have to be present at the time of testing, because of course someone with asthma can have entirely normal lung function. In fact, we hope they have entirely normal lung function in between exacerbations. So we start off with somebody who's got symptoms, check spirometry, and they're using this cut point of an FEV1 to FVC ratio of less than 0.75, which is not a cut point you've probably come across ever before when thinking about obstruction. They're trying to be very sensitive, so they're trying to use a high cut point to really make sure that we find people who might have asthma. And then they're saying, if you meet that cut point, then use bronchodilator reversibility testing. And actually, the guidelines on the criteria for bronchodilator reversibility testing have changed. And if you want to know more about that, you can come to my PFT session. And so that's now 10%. Then the next step on that pathway is to use a FeNO, so a fractional excretion of nitric oxide, which is a very simple test where somebody just breathes into a little machine. It's a little handheld thing. But I don't know if any of you have that. I don't have that in my pulmonary clinic. So that is hopefully something that more and more people will have available. And then they're listing peak flow variability, before they're saying at that point, if none of those things have given you objective data that have really pushed you to say someone has asthma, then consider referral for pulmonary evaluation, at which point they're suggesting that the pulmonologists are the people to think about when to do a bronchial challenge. So a methacholine test or a mannitol test or an exercise test to try to prove the obstruction. And up in the box at the top on your right, the diagnosis of asthma has this definition, which is that you should have consistent symptoms and variable expiratory airflow. The term obstruction or limitation has been removed from that now in the latest GINA guidelines. So variable expiratory airflow, that sort of suggests to me that airflow can be within normal, but variable by making the criteria of variability, which is interesting. And shows just how wide the range of limitation can be in asthma, i.e. doesn't have to be all that much. People can still have inflammation in their airways and have normal airway, normal numbers. Of course, in all of this, you should be thinking about what are alternative diagnoses. So I added this box of no evidence of alternative diagnosis. And of course, what do I mean by that? Well, I would say sort of use clinical judgment. You might want to consider a chest radiograph. You might consider some form of cardiac testing, particularly as you go down this algorithm and don't find data to support the diagnosis. So one of the items that was in that flowchart was this idea of using peak flow. And interestingly, GINA says peak flow variability of greater than 10% would be consistent with asthma, whereas the European Respiratory Society says greater than 20%. I think this is just showing you how difficult it is to decide on what constitutes a diagnosis of asthma. So the idea here is that you would provide somebody with a peak flow meter. Personally, I'm a fan of the simple mechanical peak flow meters because the electronic ones, the batteries run out, and then you sort of lose your data, and they need to be replaced. Whereas these simple mechanical ones, they're very hard to break, actually. You would check that somebody can use the peak flow meter. I typically ask people to stand for doing their peak flows, but sitting is fine, just not lying down, really. And you'd encourage someone to attempt this 3 times and then record the best, the highest number, not an average. You'd ask them to do it in the morning and the evening. Most peak flow meters in the box is a piece of paper with a log so they can put their numbers in. And you'd be looking at their daily peak flow variability, so their highest value that day compared to their lowest value. And you'd be looking for variability in that average peak flow variability of greater than 10 or 20%. I'm going to ask you a question now. I thought we were going to use some kind of audience response system, but I don't know for sure. Maybe it's in your app. So, 53-year-old man comes for a routine appointment, has a history of asthma. He says he's not doing great. He's taking a medium dose LABA ICS twice a day and PRN, and he's using a total of 4 to 8 puffs daily. So that's his 2 BID plus an extra couple sets of puffs per day. He's waking up at night, he's having trouble keeping up with his kids, he's avoiding the triggers he knows about, his exam is unremarkable, his O2 sat is fine, his vaccinations are up to date, his PFTs have shown in the past moderate obstruction with normalization post-bronchodilator, sufficient to meet the criteria for bronchodilator reversibility. So what's the next step? I don't know if your app's going to let you choose all that apply, but do you add a LAMA? Do you check his inhaler technique? Do you increase to a high-dose LABA ICS? Do you refer to pulmonary? Do you review his refill history? It's up there. Fabulous. Oh, I love it. I love everybody who's going to check his inhaler technique. Love it, love it. Some people considering add a LAMA, a few people going for the review, refill history, and increase to high-dose ICS. I love that the one that's not getting, that people are not going for is a refer to pulmonary. I agree, he doesn't need me yet. You can do this, you got this. It's a little bit of a trick question. They're all reasonable choices, perhaps except refer to pulmonary. So Reviewing the refill history and checking inhaler technique, that's sort of in the GINA guidelines. I'm not sure that they use these exact words, but that should be part of every time when you think, hey, what's going on? What's up now? Just checking that really what you think you've prescribed is really what the patient is taking. And sometimes, I have this patient who's actually been on a medication for years and years, and I just discovered yesterday that he's not taking it the way I thought he was, like the way it was prescribed. So amazing, years of miscommunication. Wow. So then I was suggesting LAMA would be the next thing. Referring to pulm would be to consider a biologic. So the latest guidelines say that there's not much bang for your buck in increasing from a medium dose ICS-LABA to a high dose. So maybe that's the one, next to don't refer to pulmonary, maybe that's the one to keep lower down, consider these other things first. And so, having spoken of GINA guidelines, you're probably familiar with these tables. They change slightly every year, and sometimes the changes are hard to spot. So apparently we've got a new abbreviation to use now, AIR, an anti-inflammatory reliever. So that is when we're using an inhaled corticosteroid as a reliever medication, so as a rescue inhaler. I'm such a fan of this SMART approach. I prefer it when we use the S at the beginning and call it SMART, it's just catchier. Really big fan. It makes so much sense compared to using an albuterol inhaler, PRN, because albuterol is indeed a bronchodilator. It will relieve symptoms. It will do nothing to address the underlying inflammation. So that doesn't really make sense. Let's use something that addresses the underlying inflammation. And the formoterol in there will also provide a similar experience to albuterol. So, why formoterol? Well, of course, it's the only LABA that's been studied in this fashion. But formoterol is interesting when you compare it to other LABAs from a pharmacokinetic perspective. It has a faster onset than, for example, olodaterol or salmeterol or almost any of the other LABAs. Maybe it's sort of a medium-acting bronchodilator. And so I don't know if any of you have had this experience that patients who are prescribed a formoterol-containing LABA ICS can tell you that they feel its effect, whereas typically with a salmeterol or an olodaterol, longer-acting LABAs, patients don't feel the benefit. So that's why formoterol. Then how do you prescribe an ICS formoterol for this MART or SMART therapy? So the prescription is 2 puffs BID plus PRN, up to a total of 12 puffs per day. So that means they can get another 4 doses of 2 puffs during the day in addition to the 2 puffs BID. And if your patient asks you, well, how am I supposed to rinse my mouth after that? You can say, it's probably all right that you don't. I suggest to people, I'll take a swig of water or something. I'm not sure if that's really doing anything. The studies didn't ask patients to rinse their mouths out after using the PRN doses of their ICS formoterol, and they did not have any increased oral candidiasis. What else is in here that I wanted to point out? These guidelines used to have things like Montelukast and what have you included in this list. They've taken those out. They're basically saying that inhaled corticosteroids really are the best therapy for asthma, and so don't bother thinking about other things until you've got to at least a medium dose ICS LABA. And the things you could consider are the SLIT, sublingual allergen immunotherapy. Specifically, they talk about for house dust mites. I guess because those are just so ubiquitous, and also only if your FEV1 is good enough, because otherwise we don't want to expose you to the thing that you're allergic to and potentially make your breathing worse. Other things to point out here is that they're saying that you need to reach step 5 before adding on a LAMA, and step 5 is when you'd start thinking about referring to pulmonary. I wanted to point out that the GINA guidelines have some differences with, I've now forgotten what this abbreviation stands for, this set of guidelines. And that's a lot to do with the fact that GINA gets updated every year, whereas this set of people only updated from time to time. And so these are back from 2020. And so some things have changed since then, including that GINA no longer refers to the term intermittent asthma. And that is part of how, or part of the sort of context of using a PRN SABA is just out of favor, because if you have asthma, you have inflammation, and you should use inhaled corticosteroid. In this set of guidelines, they came out before the studies on using ICS formoterol as MART therapy for mild asthma had been completed, hence that difference. And again, high-dose ICS doesn't seem to prevent exacerbations any better than medium-dose ICS. And so if somebody's reached a medium-dose ICS without full control, it is time to think about adding additional therapies where biologics are going to be the most effective of those, but do involve an injection, and so many patients would prefer to try other things first, such as tiotropium. I wanted to put a plug in for asthma action plans. I suspect that many of you already use these. My preferred one is from the NIH, so I Google NIH asthma action plan, and then I print that. It comes out in beautiful colors. You have to print it, then you fill it in with your patient. You need their peak flow to be able to fill it in completely. And so often this is a two-step process, as in I print it and I show it to them and we talk it through, and then I say, I need you to take this peak flow home and do some peak flows, or we need to get a peak flow in the clinic. But of course, I want to know what their best peak flow is. I don't know on the day they come to clinic that that's really going to be their best. The other nice thing about the NIH Asthma Action Plan is the reverse side of it has a bunch of suggestions about how to avoid triggers and things like that, which is pretty useful. I wanted to talk a little bit about severity. You're used to this kind of a table. You've seen it plenty of times. It's used for the initiation of therapy. It's used for thinking about what step am I going to start therapy at. And the severity classification has changed a little bit. As you can see, I've got that abbreviation, the NAPE, for this classification of severity, whereas GINA, like I said, have got rid of the idea of intermittent asthma, and so if you have asthma, then you have mild, and you define the severity of asthma, according to GINA these days, as by the level of treatment required to achieve control. So you can only define it retrospectively once you've achieved control. I wanted to think a little bit about these severe patients with severe asthma and point out that it's a very small number of patients who have severe asthma once you have checked their adherence and inhaler technique. So in this study, which I think was done in the Netherlands, they found that of the patients they studied, about a quarter were in that step 4 to 5. And of those, a quarter of those had poor control, and of those, only 3.7% had poor control in the setting of good adherence and good inhaler technique. So always worth checking back on those points. Okay, Asthma phenotypes and endotypes, I brought up those two words because they've become this like hot thing in asthma. So a phenotype is an observable characteristic, whereas an endotype is this, I've got a definition here, but basically you're gonna check the eosinophil level, the IgE level, and maybe the fractional excretion of nitric oxide, and then divide patients with asthma into either T2 high or T2 low, which maybe is better understood as not T2 high. Weird terminology. And then the biologics are chosen based on whether someone is T2 high or T2 low, and whether the predominant finding is high eosinophils or IgE, and there's a whole bunch of them these days, and they're generally extremely effective for patients who are T2 high. This table I was thinking of as mostly something that'd be useful for you to have as a handout and use to refer to. There are differences between all of these. Some of the differences are how frequently the patient needs to get injected or inject themselves, whether they inject themselves or whether they need to go to a clinic environment to have a nurse do the injection. So just to outline, omalizumab is the only biologic that is intended to target individuals with an elevated IgE level. Their IgE level needs to be above a certain amount, but below a certain amount. Mepolizumab, reslizumab, benralizumab are all similarly targeting IL-5, and really the thing we look at there is that are the eosinophils high enough? It's not very high, so BEC stands for blood eosinophil count, and you can see these are not actually elevated numbers. 150, 400, 150, they're within normal. Dupilumab, anti-IL-4 alpha, again looking at the blood eosinophil count. Tezepelumab, I have not yet had experience using. It's one of the newest on the block, and it is indicated for patients who do not have those T2 high biomarkers. All right, here's a flow chart. Not because, well, actually, I don't know if any of you prescribe biologics. I don't think any of this is rocket science, and so I think you're probably perfectly capable of doing that, but many of the guidelines would suggest that you refer to pulmonary for us to do that. Fine by me, happy to. And so this may or may not be something that you are monitoring. I just thought it would be interesting for you to know, even if you're not the person prescribing a biologic, that this is the recommendation, that you start a biologic and check response at about 4 months. If you're going to have response, that's a reasonable period of time, i.e. patients should be prompted or prepped for the idea that one injection is not going to suddenly change their life. They're going to need to do a few months to really see the full effect. If someone truly has not had a good response after about 4 months, you would just stop it and you might consider a different biologic. There's this idea of maybe unclear, and you might extend the trial. Another thing that I think is really, or a couple of things that I think are worth knowing are that after about 3 or 6 months, if somebody with asthma has good control on a biologic, you can consider stepping down their other therapies. I do not have this patient, but colleagues of mine have patients who have managed to stop all their other asthma therapies, everything. Which then, of course, begs the question, should we stop the biologic? And the answer is probably not. I have tried that, and it didn't work. I agree with the guidelines. We probably shouldn't. The other thing that can happen is people can lose response to their biologics. So they had a great response, and now their asthma is not well controlled anymore. You could develop antibodies to the antibody. That's a bummer. And then you would consider a different biologic. So that was 20 minutes of asthma. Oh, it wasn't, it was slightly more. This is my interim summary, we're moving on. Okay, COPD. 73-year-old woman, she has COPD. you have spirometry from before, which showed an FEV1 of 38% predicted. She's come for a routine appointment. She's doing well. She takes olodaterol, tiotropium once daily, and albuterol PRN. She can walk up a flight of stairs. She hasn't used prednisone in over 2 years. I've given you actually conflicting information about her FEV1. Sorry about that. Sort of similar, same ballpark. She quit smoking quite a long time ago. Her exam is not all that interesting, although on exercise, her O2 saturation drops to 87%. So, what should you do next? That could be just one person. If it is, I love you. Yeah, interesting. So, smattering of other things. Yeah. Great. Thank you all for playing the game. It's actually good for your brain to stay awake and to make a commitment, because it primes your brain either to learn something slightly different or to set that synaptic pathway as the right one. So the thing I was going for there was refer for pulmonary rehab, but I recognize that there are potential other things to consider. So, might you check an arterial blood gas? Well, we know that pulse oximetry is not that perfect, or not perfect, that the error on pulse oximetry can be 6%. It's quite wide. That the skin tone of the person that we're talking about might actually push them into larger error on pulse oximetry. So the idea that you might want to consider a blood gas, I understand someone thinking of that. With a resting sat of 95%, I probably wouldn't do that. Inhaled corticosteroids, we'll talk more about this, but they're really indicated for patients who are having exacerbations. And prescribing oxygen on exertion, we'll talk a bit more about. I would go for pulmonary rehab first before considering oxygen on exertion. So when I'm seeing my patients with COPD, I have a couple checklists that I use to think about them, and I'm sharing them with you now. I hope they're helpful. So I want to know that the history is consistent. And what do I mean by that? The history of somebody with COPD is generally that they describe a progressive worsening shortness of breath on exertion. And one of the things that I review with patients is that we're not going to turn that around. It's unfortunate we do not have therapies. Modern medicine cannot get you back the lung function that you have lost. And our lung function gets worse with age. And so whether you have COPD or not, your lung function will get worse over time. So I want to check that we really have spirometry that shows obstruction and that we don't have chest imaging to show us something else going on. For example, pulmonary edema can show obstruction or restriction or a reduction in DLCO on PFTs. And so if somebody has decompensated heart failure on the day they do spirometry, you could get any or all abnormalities. So the next part of my checklist is thinking about management, where smoking cessation, inhaler technique again, pulmonary rehab is high, and I will check if somebody's done pulmonary rehab, are they still exercising? Think about the appropriate medications for their GOLD group, which we will come back to in detail, and then I'll talk more about oxygen therapy and advanced therapies. And that's the point at which I would be suggesting to you for referral to pulmonary medicine, is if you're thinking somebody might benefit from an advanced therapy. And I'll tell you what I mean by that as well in a bit. So, pulmonary rehab, there is so much data for pulmonary rehab. It is the single best therapy we have for COPD. It is more effective than any of our medications. Some patients may consider that unfortunate because some patients may prefer to take an inhaler than do something for themselves. I get that. We've probably many of you have done physical therapy for something that has, something that has hurt in your body, and it's a pain. You have to get to the sessions, you have to keep doing the therapy, you have to do it for the rest of your life. It's the same with pulmonary rehab. But there are no side effects other than your time. And look how happy you'll look if you do it. I mean, just take this photo home with you. Okay, so gold grouping. It used to be A, B, C, D, now it's A, B, E. I'm not the person who made this grouping, but this is what it is these days. You work this out by asking people about their symptoms, where really the main symptom is about their shortness of breath and also about their exacerbations. Down at the bottom, I'm showing you what the GOLD guidelines are asking you to use to determine whether somebody has low or high symptoms, so the Modified Medical Research Council system or the COPD assessment tool. The COPD assessment tool is lovely, but it's like a form. You probably have to hand it out to people in the waiting area and then have them come in. My clinic does not have the ability to do something like that, so I use the Modified Medical Research Council, not only because it's British, but also because it's simple to remember. So the cut point is an MMRC of greater than 2, and that means it's the difference between I can walk on the flat without stopping, or I have to stop when walking on the flat because of shortness of breath. Pretty easy to remember. That's the cut point between A and B in terms of symptoms, and then in terms of exacerbations, it's about the frequency, but also the type, as in one inpatient exacerbation in a year gets you into that higher exacerbation group, whereas just one outpatient exacerbation is considered not too bad. Then in terms of initial therapy, these are the guidelines. You can see, I mean, the A group, it's kind of hard to think, how do we know about these people? Some of them maybe got spirometry for some other reason, because apparently they're not short of breath when walking. So LABA plus LAMA has really become very standard. The guidelines are not really recommending using either of them separately. If you need one, just use them both. This makes a lot of sense to me. The main thing that LAMAs have been shown to do is reduce the frequency of exacerbation. That's a big deal. And then LABAs, people feel better. They can walk further and do more. So the key thing here is that in that initial therapy, there's no group who straight away get an ICS. You might consider it in this small handwriting. And why is that? Well, inhaled corticosteroids increase the risk of pneumonia with a number needed to harm of 17, which isn't very high. And so, did not mean to do that. There are suggestions for who to consider ICS for strongly and who really shouldn't get it, and then there's a gray group in between because, of course, nothing is completely black and white. So patients who are having frequent exacerbations, who have higher eosinophil levels, again, a cut point of 300, that is within normal range, and anybody who actually has asthma, they should get or should be strongly considered for inhaled corticosteroid. And then there's other people who really you shouldn't use an inhaled corticosteroid for. So if people are having frequent pneumonia, they should not get an inhaled corticosteroid. And this is tricky because people get admitted to hospitals and then their discharge diagnoses say pneumonia and COPD exacerbation. From the purposes of thinking about inhaled corticosteroids, if somebody has a pneumonia, of course their COPD is worse. That's not the main issue. The pneumonia is the main issue. And watch out for anybody who might actually have a mycobacterial infection because that can really get worse on an inhaled corticosteroid. So there's also thinking about who do we stop inhaled corticosteroids for, because maybe someone met criteria, but maybe now you're seeing them and they haven't had an exacerbation for a year. This would be a good time to see if you can stop their inhaled corticosteroid. And typically, you can just stop it cold turkey. And the way I do this is I order the new set of inhalers, whatever that may be, and I say, when these arrive, just stop your old ones, start these new ones. If in the next 2 to 3 weeks after making that change, you really feel that your breathing has changed or your symptoms have changed, your cough, whatever, just go back. Just switch them back. Give me a call, leave a message with my nurse, and we can think about that in the future. Then the next time I do that, I might try a taper. So I might try splitting out their inhaled corticosteroid as an individual inhaler and then tapering it over a month or two. Or maybe I will find out when I check their blood eosinophils that actually it's high and there's somebody who just actually does have quite a bit of inflammation and benefits. Whew, I've done the same mistake again there. The Zoom error is still there. It's real fun, isn't it? Okay, so the GOLD guidelines from 2025, they've got some fun new medications in here. So this is after initial therapy. So this is a person who's coming back to see you, they're already taking some set of inhalers. You can see that now they have included this medication whose name I have not quite got used to saying, ensifentrine, something like that. It's probably got another name as well. And over here, we've got dupilumab as an option as well. So I will speak to all of these. Oh yes, mepolizumab, since these 2025 GOLD guidelines were developed, mepolizumab has also been FDA approved for use in COPD. And I disagree with the guidelines and want to add pulmonary rehab. Someone was taking a photo. Please take the photo again, delete the last one. This is what the guideline should be. Good, excellent. I'm going to hold for a moment for their photos. Okay, going to talk a little bit about azithromycin and roflumilast. I don't feel like my job is to tell you exactly when you should refer to pulmonary medicine. I think that's going to vary depending on your institution, where you work, how easy or hard it is for you to get a patient to a pulmonologist. These two medicines, I think, are really reasonable for primary care to consider prescribing for the following patients. So they're both indicated for individuals who are having frequent exacerbations despite using triple inhaled therapy with good inhaler technique and on medication refill actually taking them. So azithromycin you are very used to. It's a macrolide antibiotic. We think that it's not the antibiosis that is the beneficial element here. We think it is its anti-inflammatory properties, and that in this situation it would be dosed 3 times a week. There is a lot less evidence for this being useful for individuals who are currently smoking than those who have quit smoking. And of course there are significant risks, and the guidelines are not super helpful on what to do to try to avoid these. So in terms of cardiovascular mortality, where what we're concerned about is sudden cardiac death from anarrhythmia, from prolonged QT, the recommendations are to get an EKG before starting it, and whenever a new medication is added that would prolong the QT interval. There's also a risk of hearing loss, and so the recommendation is to get an audiogram. And then I think there's a recommendation to repeat audiograms, cue something that just seemed really frequent to me. And also, if you've already lost your hearing in between those audiograms, then how helpful is that? So I struggle with knowing exactly how to deal with those issues. And I definitely talk to patients about the hearing loss side of things. The sudden cardiac death, it's very rare, but it is there. So what do? Well, I try to use roflumilast whenever I can, because it doesn't have quite sort of a risk of death attached to it. So it's a phosphodiesterase 4 inhibitor. It's a tiny little tablet. The tricky thing is for roflumilast is that it's indicated for the same population of patients, but only those who have chronic bronchitis, so only those who are having a chronic productive cough. its main adverse effect, I've actually seen no issues with the suicidality. That is, of course, on the list of possibilities. But the GI toxicity, which can be really awful, terrible diarrhea. And they say that this is reduced by starting at a half dose for 2 weeks. My personal experience, or that of my patients, is that they either get diarrhea or they don't get diarrhea. So they either hate me and tell me they're never taking that pill again ever, doctor, what were you thinking? Or they have no problem at all. But I still start at the half dose, just in case. Patients can also experience weight loss from roflumilast. Now for the newies, so I'm going to practice this. Ensifentrine, O2 Virae, is a nebulized medication. So it's a phosphodiesterase 3/4 inhibitor, so similar to roflumilast. And it there've been 2 studies of it, and the FDA approval was only acquired once they had done both of those studies and combined their results, because neither one of them was so convincing alone. Interesting. The main outcome that was clear was that people could walk a little further on their 6-minute walk. But also, in that pooled analysis, did reduce moderate severe exacerbations. But only in patients who were taking a LAMA or a LABA plus minus an ICS, so not patients who are on triple therapy. So we haven't seen if this is really effective at reducing exacerbations once you've already used inhaled therapy. The GOLD guidelines put this in the dyspnea arm. So I have not even considered using this yet. I work at the VA, and I'm sure it's not approved yet for me. It's very expensive. Look, it's more expensive than pulmonary rehab. That's interesting. Who put that there? So now I'll mention dupilumab and mepolizumab. So I've already mentioned them. They're biologics. They're used in asthma. They've now been FDA approved for use in COPD. So they have been shown to reduce acute exacerbations of COPD in patients with COPD on triple inhaled therapy. So actually the group that are already receiving the therapy that I have already recommended for them, and with a blood eosinophil count of at least 300. Anecdotally, my experience with my patients has been that I haven't seen a magical improvement, whereas with patients with asthma, I have seen a magical improvement. And the study suggested that it was going to be a pseudo-magical improvement, and I wonder how many of the patients might have been a COPD asthma overlap individual. So you'll see that being used. You will see it. I don't know yet if we'll see in real world if it's super effective. So we're going to talk about oxygen therapy next. Oh, I'll just mention vaccinations. They actually save lives. I mean, I'm sure you're all believers, but this is really important. I sort of wonder about where I should put things on my checklist. Vaccinations probably should be higher. So talking about supplemental oxygen therapy next, the studies from which decisions were made about using supplemental oxygen therapy are from the 1980s, and they looked at patients who had severe hypoxemia, and those studies got extrapolated to prescribing home oxygen for people with moderate or exertional hypoxemia, and more recent studies have shown no evidence of benefit for people who have moderate hypoxemia or just exertional desaturation, as the case that I presented at the beginning. The other tricky thing about oxygen, together with the trickiness about pulse oximetry, is that there are a number of studies showing that supplemental oxygen therapy is bad and may even kill people. So this is a study from Australia looking at patients with acute exacerbations of COPD, and they had increased all-cause mortality if they were assigned to the standard of care arm as opposed to the carefully titrated oxygen arm. So if their oxygen was allowed to get higher than 92%. So I prescribe oxygen for patients who have a resting low oxygen saturation, and I ask my patients to get a pulse oximeter for all of their, even despite all of their problems. I'm being told it is time, and so the thing we didn't get to talk about much was advanced therapies for COPD, which is fine, because if you're concerned someone should have an advanced therapy, refer them to pulmonary. The main things here is that patients need to have relatively few comorbidities. They have to have quit smoking and completed pulmonary rehab. They need specific findings on their PFTs, and if it's transplant, they need a bunch of other things as well. So, my summary is here. You can take that in. I thank you for your attention.
Thank you so much for your talk. That was an amazing, fast-paced summary on both COPD and asthma. So now we're going to take a second to do question and answers on both those last two sessions. So I do have a few questions to start with on our health equity lecture by Dr. Dean. I'm going to share one from the live question and answer. So the state of Washington has explicit language prohibiting race-based admission decisions, and we're seeing the repercussions of that. And an example is given from the UW School of Medicine entering class of 2022. Of the 270 admits that year, not a single black male student was admitted across all of WWAMI. Yet, there's no law against admission based on where they graduated college or university. Are there any examples of pipeline programs in the US that have utilized this model to help with admissions disparities?
Thanks, that's a great question. There is a law in the books called I-200. So we've done, at the University of Washington, we've done holistic kind of admissions for many years. So, but we've still struggled with matriculants. And I think it's because, you know, there are multiple systems of bias that have led to a poor URM applicant pool. There are pathway programs that we've employed for many years have not really worked. To be honest with you, they've identified folks who have already been STEM identified, who are capable of getting into medical school, and we kind of help them along. But I think we need to do better. So an example that we can use in WWAMI is our outreach in my Center for Indigenous Health. We go to tribal colleges, we go to community colleges. What we try to do is really formulate a relationship with these kids. And you can think of it as recreating kind of a middle class upbringing. So my children will have a much different experience in applying to college and possible professional schools than I ever did as a first generation college graduate. So what I want to do is I want to recreate that experience for tribal kids, for black kids, for Hispanic kids, for South Asian kids, and really kind of normalize that experience for them. I don't want it to be notable that a URM student has, gotten into school with us and is going to be doing great things. I just want to, plainly state that that's a normal kind of occurrence. I think I answered the question. Okay.
Great. One more question for you, Dr. Dean. We wondered if you could speak to your metaphorical go bag and whether you would share what's in your go bag.
No, that's great. That's great. Thank you. And, I think I agree with Dr. Vassal around this point that I have to check my own biases. I would say. But I try to remember why I went into medicine in the first place, and really kind of hold on to that value. Another thing that I really employ a lot is humor, I would say. And I love to, joke around with my patients, talk to them about their families, do a little bit of social history. So I try to bring a little bit of that into my encounters, and that's really kind of helped, I think, buffer not only myself, but buffer my patients from all of the chaos that has been circulating lately. Thanks.
Great, thank you so much. And then I also have some questions for Dr. Adamson, if you don't mind coming back up. So one question from the audience: pulmonary rehab wait times are 6 to 9 months. What can we advise our patients to do while they wait?
Great question. I think one of the things that patients are concerned about is that they're going to do themselves damage, that it is dangerous for them to exercise because they get short of breath, which I understand, because feeling short of breath when it's bad is kind of like feeling like you're dying. So I really get that. And I think one of the things that you can do is point out to them that when they were younger and healthier, they would exercise to the point of feeling short of breath, and they didn't consider that dangerous. They can still do that, as in it's okay to get short of breath and then pause at that point. And so, yes, big issue, any form of exercise is better than none, and I think that that sense of fear is a real barrier.
And then is there an initial number of pulmonary rehab sessions that patients need to go to with that first referral? Like, is there a standard referral number?
The original studies were 8 weeks of twice-weekly therapy. Many community programs are actually 12 weeks long. Interesting, maybe that's part of the problem. And often will ask for continuation. Which I understand, because patients are probably asking for it, because it may require having a therapist telling you to do your therapy and telling you that you are safe while you're doing it to really feel like you can do it. So again, I think the empowering of once you've done a course, you just got to keep doing the exercises yourself. And if you don't use it, you lose it. So what is, I don't know what the minimum required to get a benefit is, but the original studies were 8-week courses. Many courses are longer than that. Patients often want more. I would really try to encourage them just to keep exercising themselves.
Great, thank you so much. And I want to open it up for another round of applause for Dr. Dean and Dr. Adamson.